Okay, I think she's recording now. We
I'm
are good to go.
recording.
Dr. Ugo is not a co-host. Can you please make a co-host? All right, sir. Well done. Thank you.
Okay. Prof, I'm ready. If we're ready to start, can you let me know?
Yeah, so it has been fantastic to have chosen this part of reviewing guidelines. And I believe that this is going to be a big breakthrough in our clinical practice for our courts, and also with help the next generation who continue this practice. So one important thing I just would like to share as an experience is that I've had, when I was in India, there's this something they do about clinical reviews. So they have times for reviewing guidelines, especially when new guidelines are out. It's mandatory that their residents must have a session with all the consultants to review the guidelines. And also it's mandatory that they also review the randomized control trials, like clinical journals that make up the guidelines. So I would now say in effect that since we have started an overview of the guideline, one thing we should look forward to also adding to the topics will be the randomized trials that make up these guidelines. What are the challenges with those trials?
Okay.
What's, if we have to do trials, what can we do better? So that means like critiquing the baseline for the guidelines, which are the clinical trials. So I would suggest that we continue this our court and see added benefit of further teasing out the guidelines in nearest future with topics shared around all of us. So I really appreciate Dr. Kweki spearheading this and starting with this guideline. So I wish us a beautiful time in today's discussion. Once again, you're highly welcome. So Dr. Kweki, sir, over to you, sir.
Thank you. I want to say once again, thank you, Prof, for always being around, especially, I won't forget when we started, and your presence was really something that made something very simple. So thank you so much. Good evening, consultant. Good evening, fellows. Good evening, all colleagues on the platform. This discussion is going to be a summary of the guideline in management of NSTEMI. It's a long discussion and guideline. I'll make an attempt to do a summary. So what you're going to see really is actually summaries of a lot of things like Prof have said. We'll have to look into each of those striking trials and see how we can also discuss them. So the idea is for us to eventually improve our practice now and in the coming generation. I'm sure I have about 40 minutes thereabouts because this discussion should take us everything we question for about an hour. So I'm going to do a summary. I've also gone further to drop the guideline on the platform. So also from a portal for anyone that want to go through them. A lot of the trials are there. They're all summarized. You can go through them to have some detailed information. So so this is just the outline and look at the aim of our discussion today. Overview of NSTEMI diagnosis, risk stratification. What does the guideline say about biomarkers, medical management, spontaneous intervention? We'll look at for some special populations, and then what is the take-home message? So, like I said before, just to reiterate the point I said, that we need to know what the guideline says about diagnosis of NSTEMI. What does it say about risk stratification, biomarkers, and all the rest? So just a way of introduction, we all know what is NSTEMI. NSTEMI is, from the name, is a non-ST segment elevation myocardial infarction. We know that it's usually due to atherosclerotic plaque rupture, because the fibrous ends of the plaque might be prone to rupture. So once they rupture, they can embolize to distant part of the coronary arteries. And usually they form thrombus. And from there, they can have total vessel occlusion, usually less than 100%. In instances where is completely occluded, you see that kind of conditions in patients that present with STEMI, and that is usually classical on the ECG presentation, which is, again, can be easily identified, and then that can be sought out immediately. But NSTEMI tend to present in different pattern, and it's good for us to pick up this patient and then to be addressed. So clinically, patient try to present with ischemic pain, a typical vaginal pain, which is sternal radiate to the neck, and sometimes to the arm, sometimes to the left arm, right hand. Sometimes patient can describe the pain as pressure, tightness, or burning sensation. It can be any form exactly. And usually brought up with the exercise, and then relieved by rest or GTN after 5 minutes. And patients that have NSTEMI, the hallmark of NSTEMI is acute chest pain. Someone that apparently have not had chest pain before suddenly develop chest pain acutely. So that's the hallmark of NSTEMI. Or someone that have had stable angina pain for a while, suddenly you realize that the pain has increased recently in frequencies, duration, and severity, such that patient now need more of GTN to abort the pain. And even at that, if you receive a GTN, the pain is not aborted within 5 minutes. So these are things that suggest to you that there's an ongoing event, and need to address it. Never forget the group of patients that we address as seems to have angina equivalent pains. They are the individual that have epigastric pain, have MI presenting with epigastric pain. So this is typically what I have just discussed so far. And these are the ECG changes, which I'm sure we are used to all this. This is what happened as per biomarkers. I'm sure we're used to all that. So let's look at the guideline in terms of diagnosis and risk stratification. Now, if you look at, now let me quickly talk about class of evidence and level of recommendation. I think it is quite, I didn't put a slide there, but I just remember now. Class 1, Class 2A, Class 2B, Class 3. So whenever you see Class 1, it just tells you that it should be recommended, it should be practiced. Whatever was recommended, is beneficial to the patient. And for that, it should be done. So that's what Class 1 indication means, that whatever has been stated. For instance, this Class 1 indication for it is recommended to base diagnosis and risk stratification on clinical history, symptoms, vital signs, ECG, and your troponins level. So that is the guideline statement on diagnosis, and it's a Class 1 recommendation. So it means that it should be practiced because it's beneficial to the patient. So again, you see level of evidence. So level of evidence, B, C, or A sometimes. So these are based on the kind of trials they do. So there's a way they classify all the trials that has been done. So you will have the meta-analysis. That's the first one, meta-analysis. I don't know whether I should go over that. We'll discuss it later, but let me just give you a summary. You have the meta-analysis. Meta-analysis is when you combine more than one randomized controlled trials. So all the trials will be done all over the world, in US, in Europe, in Africa, and the likes. You bring all the trials together and look at what all the trials are saying. So that kind of analysis is meta-analysis. So whatever analysis that came out of meta-analysis is level of evidence is A. Okay, so by the time you go down to just only one randomized control trial is B. By the time you go there to C, you start talking about case control, cross-sectional studies, expert opinions, and all that come into play. So those are the level of evidence. But what is so important to our discussion is the class of evidence. So whenever you see class 1 evidence, it just simply tells you that that recommendation should be practiced because it is beneficial to the patient. So what the guidelines saying about diagnosis here is that you must take a good history, and that history is important to be able to look at the typical nature of the chest pain. Sometimes it may be atypical. Okay, whichever it is, clinical history, symptoms, ECG recording, and troponin are important. Then if you look at the next statement, it says that you should measure cardiac troponin with high sensitive assay. In fact, that is what is recommended in the guideline. But I also know that some centers may not be able to afford this right now. So high sensitive assay immediately after admission and obtain a result within 60 minutes of blood sampling. So that is recommended. And now the third one said you should be able to record an ECG within 10 minutes. And this should be interpreted by an experienced physician. And if you are still in doubt, probably the patient still have ongoing symptoms and you think that this may be NSTEMI, but you are in doubt, after the first one, you can record another ECG, okay? Because we all know that there are potential for dynamic changes. So NSTEMI occurs in dynamism. So it could be normal now, but after some hours, it could become suggestive. Sometimes it could be suggestive now, but because of resolution and collaterals, after some time it could resolve. So serial ECGs is always important to be able to pick dynamic ECG changes. Now, it's recommended to obtain additional 12 leads of ECG in case you are still in doubt. So you can continually do serial ECGs. In fact, you can just connect the patient to telemetry or continuous cardiac monitoring where you can easily print out. So you can keep tracing the patient. As you go further, you realize that part of the monitoring, you need to put the patient for at least 24 hours of telemetry. And if you think that there's an ongoing pain, you can continually monitor the patient telemetry-wise for up to 5 days. Now, there's the concept of 0 hour and 1 hour, 0 hour and 2 hour, and 0 hour and 3 hours. The concept is that you should do your troponin in the 0 hour. 0 hour means once the patient arrives at the hospital. So do your troponin. Please call my attention. I can't see time with me here. Once I hope I'm not spending too much time. So the point here is that your cardiac troponin, as the patient arrives, you should collect the sample. Okay, then after an hour, collect another sample. So this 0, 1 hour we'll talk about is not when the result comes out, it's the time where you collect the samples. So we also understand that turnarounds may be different from center to centers. In fact, some centers can't even get troponin until 24 hours later, so some can get at presentation. So if you can get it at presentation, that's very fantastic. You can get another 1 hour. Then if you think that the patient is, if it's still normal, you've done the first one, second one is still normal, you can do another one. So you look at the changes. That's very important. More than 5-fold increase in troponin is suggestive of an ongoing event. So you look at the changes, is it more than 5-fold? So that's suggestive of an event. Or sometimes is it declining because the patient may have had an event for some time before coming to the hospital. Either way, is it increasing or is it declining? Is important. But in my center, we still do 0 and 3 hours, and a lot of reason for that. So again, if you, that's for cardiac monitoring. So we need to do the troponin 0 hour, 1 hour, 2 hours, or 3 hours, depending on logistics and how it can be done in your center. If you're suspecting involvement of the right side or involvement of the posterior aspect of the heart, you can reverse your leads on the ECG as appropriate. Now, I need to also state here, if you look at this, it says that it should be considered to use established risk score to prognosticate estimation. So we'll talk about that later. The gray score is considered. So, I talked about the class of evidence at that time. Class 1 means that there are a lot of evidence. So it's beneficial to the patient and it should be done. Class 2A means that there are both evidence for and evidence against, but the evidence for are more than the evidence against. So meaning a lot of people does it, but there are some people that think that is not necessary. That's what class 2A means. While the other one, class 2B, means that there are evidence for and against, but the one that are against seems to be more than those that are for. That is, a lot of people don't practice it. Fewer people practice it. So you see language like it should be considered. So once you see it should be, that tells you that the evidence for is more than the evidence against. But sometimes you see it may be considered. It may, once you see the term may, it just tells you that evidence against are more. So use your expert opinion as a clinician to take a decision on such patients. So we're talking about using other, apart from cardiac exams, troponin, they're also talking about other biomarkers, which we'll discuss in the next other slides. Now, this part is important: imaging, NSTEMI, and patient imaging. It is important, recommended, class 1 indication, as you can see. It is recommended that patients should have an echo done. The reason for echo, you want to assess for any features to suggest ischemia, or you want to rule out cardiac complications such as heart failure, rupture, and all the rest. You want to be sure that there are no cardiac complications. And thirdly, you want to do other invasive, non-invasive approach, especially when you are a doubt. And the way NSTEMI presents low, intermediate, and high risk. So you have 3 group of patients. I think we'll talk about that in one of our sections. So on the extreme group of patient, a patient that comes to the hospital, they got chest pain, ECG is suggestive, CHOP is positive. That is straightforward. Make your diagnosis of NSTEMI, admit the patient, cut the patient, stent the patient straight away. There are other group of patients that come to the hospital. They got chest pain, not very typical, doesn't seem to have any bad risk factor, but ECG is normal, troponin is also normal. You really be able to say that this group of patients, they are lower risk. So for that reason, they are likely going to have non-cardiac pain. But there are a group of people that lies at the middle, which we refer to those that have intermediate risk. sometimes you are trying to rule in or rule out. So that's the concept of using your troponin 0 to 1, 0 to 2, and 0 to 3 hours, as the case may be. Rule in, rule out. So sometimes you're able to rule in, just like the example I gave, meet all the criteria, you rule in the patient to have NSTEMI, then you take it from there. But some instances, you are also able to rule out, and then you're able to say that this patient doesn't have NSTEMI. But there are other group of patients that lies within the middle where you cannot say exactly whether they have STEMI or not. So how do you approach those group of patients? Number one, you can make use of the risk factors. So if the patient have a load of risk factors, even though chest pain, gut chest pain, ECG not suggestive, troponin not suggestive, but someone that had previous myocardial infarction and probably had stent to one of the vessels, and the other vessels were not significant for stenting. Maybe they had mild diseases, and now after sometimes coming down with another chest pain, even though trop is negative, you want to look at those group of patients as a possible candidate that may be having an ongoing event. So one of the things you can do for those patients is to do non-invasive procedures. So you can see that non-invasive procedure is a class 1 recommendation for this group of patients that you're not quite sure of what it is. Because one of the things you wouldn't want to have in your hand is to say that this is a non-cardiac pain, then the patient go home, have an event, cardiac arrest, and patient dies from there. So you wouldn't want that. So you can do non-invasive testing for inducible ischemia. So practically, you can make use of cardiac MRI. Cardiac MRI is very good to use because it can tell you the perfusion as well as viability in case there is an event. In fact, it can even tell you if it's a new problem, vis-a-vis you see an edema, or if it's an old problem, you're going to see a scar or an infarct. So cardiac MRI is something we can use. Apart from cardiac MRI, you can make use of your stress echo. You can also make use of typical SPECT or the PET, as the case may be. Now, it is said that stress ECG is not very sensitive sometimes, but if it's what you have within your reach, is something that you can use. But I think that almost every one of us can do stress echo. The typical dobutamine stress echo can be done, and then you're looking at for inducible ischemia. But sometimes when you have problem with the regional, when the endocardium is not well delineated, you can make use of your contrast into echo to be able to delineate the endocardium properly, because you're trying to assess regional wall motion abnormality. So you need to see this wall properly. So one we can do if all these are not available is the CT coronary angiogram. Is a good test that can be used to rule out, an ischemic process. But one of the limitations, again, is that of calcification, and using it in elderly people may not give you a good result because you just see calcification all around. In fact, in the past, because of that, we're doing a lot of angio for these individuals that came out to be normal. So extensive calcification, especially in elderly, may not help you. But for those that are a bit younger, CT angio with FFRO guided procedure, it's a good test to rule out an event. So monitoring, I think I've talked about monitoring briefly. Every patient that you suspect to have an event, the guideline, the class 1 recommendation that patients should be monitored up to 24 hours for those that have low risk. But for those that have high risk, you have to monitor them more than 24 hours, sometimes up to 5 days. You're looking for ongoing ischemia, ECG changes, and then arrhythmias that might be fatal. in this group of patients. Then I have talked about biomarkers extensively. You can see that it's a class 1 recommendation that troponin, the high sensitive troponin, a serial measurement of the high sensitive troponin does not just give you a diagnostic rule, also prognosticates the patient. So once you measure the troponin serially and it keeps going up serially, that's potent a bad prognosis. So you need to intervene early in those group of patients. So it just tells you that there's an ongoing event, and if you don't do anything, patient that was initially NSTEMI can become STEMI, and it can have arrhythmias that can be fatal. So now we've also talked about, so you can see here is a class 2A recommendation that BMP should be done. So the language here is should be done for prognostication purposes, because of, if the BMP is rising, it just tells you that some heart failure, myocardial stress, and all that. So, and it begins to rise, tells you that cardiac, apart from the ischemia going on, is beginning to affect cardiac function. And you lower the cardiac function, they boost the prognosis. So apart from just doing the cardiac troponin, it's also reasonable to do your BMP or MPRO BMP. Now, class 3, I talked about class 1, class 2A, class 2B, class 3. Class 3 just tells you that it's not recommended. So that's why you can see here they're trying to measure other biomarkers, even as far as CKMB, is not recommended for diagnosis or prognostication, at least for now. So maybe in the coming days, coming years, we'll have some trials that will do that. I've talked about scoring before, and gray score model should be considered for estimating prognosis. And this is a class 2A recommendation. So meaning some more are in support that should be used, fewer guys or people are in support that they should not be used. So just to be aware of that. Now, let's talk about the medical management now. So once a patient comes to the hospital, you have taken your history, assess the patient, and you think that finally think that the patient have NSTEMI. What do? You need to load the patient on antiplatelets. The typical recommendation is aspirin 300 milligrams starts, and then you continue 75 or 100 thereafter, depending on the ischemic body of the patient. So, but typically most centers, they just start 300 milligrams start on aspirin, load those aspirins, and then continue 75 milligrams daily. Then there's also a class 1 recommendation that you can start your P2Y12 receptors inhibitors. And these includes clopidogrel, ticagrelor, prasugrel, and cargrelor. These are the 4 P2Y12 receptors inhibitors we have right now. It is said right now that ticagrelor is what is recommended to use first. So a patient comes, put on aspirin, and then you put on your ticagrelor. Ticagrelor is at the dose of 180 starts. You load the patient with 180, then continue 90 BD. So that's what is really recommended, except you can use your prasugrel if you think that the patient is proceeded to PCA almost immediately, and this is a class 1 recommendation. So another reason why you want to use clopidogrel, if ticagrelor or prasugrel are not available, so that's the typical environment we are in Nigeria. If they are not available, or for whatever reason, they are contraindicated because the risk of bleeding tends to be higher with ticagrelor and prasugrel. So if there is a contraindication vis-a-vis bleeding risk, or they are not available, then you can use aspirin and clopidogrel. Clopidogrel, you also give at a dose of 300 milligrams, that's 75 milligrams daily. But if the ischemic body is high, you can make it 600. So I think just because of time, I can't, I'm not with the time here. I hope I'm not overshooting time. Just give me 1 minute. Let me take off time here. 1 minute, please.
Don't worry, Dr. Ugo is following it up. She will soon respond to you when it's time. You have like 8 more minutes.
8 more minutes.
Yes.
Okay.
Yes, please go on, sir. You have 10 minutes more.
10 minutes.
Yes, yeah.
10 minutes,
Okay.
yes.
So this is the way just to assess bleeding risk. So the guideline, there are a lot of score that you can use to assess bleeding risk in a patient. But the guideline also recommend using the academic research consortium, for assessing bleeding risk. You get the slide, and these are the things you look at, minor or major, to assess the patient. These are things you can do to reduce bleeding risk in a patient. Very important is that once you're putting the patient on aspirin, ticagrelor, remember to add PPIs to reduce the risk of bleeding. These are antithrombotics and the mechanism of actions. The idea eventually is to prevent the formation of thrombus, either by preventing fibrin formation or platelet formation, either of them. So talking about, I've talked about the use of antiplatelets, use of anti-ischemic medications, class 2, class 1, class 1 indication. So sublingual nitrates, it should be prescribed on a PROM basis for the patient. So if there's an ongoing pain, patient can take it. Or if the patient is having severe hypertension and uncontrolled, you may want to use your IV nitrate. So apart from nitrate, you can make use of your beta blocker. In fact, apart from addressing the ischemic pain, it's also beneficial to the patient and be shown to reduce morbidity and mortality. So one of the things you want to do for a patient that comes in NSTEMI, you want to be sure that they're receiving their beta blocker, because does it just reduce the pain? Also is important in terms of outcome. Then if pain continues to worsen, you can use your calcium channel blocker, amlodipine, ifedipine. They can help, verapamine and all the rest, but you need to look at the background of the patient. These are the first line, the 3 drugs you want to use on the first line: is a beta blocker, calcium channel blocker, the nitrate. Second line basis, you want to make use of your Nicoro-D, Ranona-Z, and trimetazidine for the patient. So, and they are class 1 indication. Look at class 2A. Say a patient with suspected vasospasm, calcium channel blocker and nitrate should be considered, and beta blocker avoided, because that will worsen whatever that's going on. So patient with vasospastic angina, you teach towards calcium channel blocker and nitrate, because it's going to relax the vessel. So we all know that statins is important in patient. You can look at the slide later. We all, for patients, we talked about beta blocker already, so can look at that later. Now, one thing I want to also look at here is the AC inhibitors. So once you do an echo for the patient and EF is less than 40, remember to start the patient on AC inhibitors. And if the patient is diabetic and CKD and there is no contraindication, you can start for the patient. I've talked about PPIs, spironolactone, or the MRAs, eplerenol or spironolactone. You want to also start once the EF is less than 40. Especially if there is no contraindication. Talk about PPIs because the patient is receiving dual and the platelet therapy. So this is just management. You want to do PCR for the patient. So what is important here, I want to really talk to us about a guideline, is that the guideline, patient with NSTEMI, the presentation could be very crazy and very dynamic in terms of their presentation. So STEMI is so easy to address because the patient have ST segment elevation, then you need to open up the vessel immediately. But patient with NSTEMI, they can be very crazy. So the guideline recognized three approach in terms of interventions. First is the immediate interventions, early intervention, or you can select the patient that you want to intervene over a period or days. So the first group of people are those that you want to intervene less than 2 hours. They are the guys that have hemodynamic instability, cardiogenic shock, keep having pain in spite of the anti-angina medication, that are refractive to the usual anti-angina medication, have life-threatening arrhythmias, ventricular tachycardia, VF. They're already having mechanical complication of MI, acute heart failure. These are the guys you want to intervene immediately. So guideline recognize this group of people that you need to do something immediately. If not, something will go wrong. Then the other people are the early intervention within 12 hours. Okay. So these are the people that you have made a diagnosis of NSTEMI, but they are quite stable, no chest pain. So you can plan them for the next 24, within the next 24 hours for you to do your procedure, or they are having dynamic ECG changes, or they are the guys that had out of hospital cardiac arrest and then were resuscitated, achieved spontaneous respiration. You can wait at least for within 24 hours for that to be done. So while the last group of people, they had NSTEMI, you made the diagnosis, you can selectively pick the patient you want to do, especially in a center where you have a lot of volume. You can't do everybody at the same time. So you can selectively prepare the patient you want to be. So the guideline recognize this group of people. You can see that this is a class 1 indication. A class 1 indication, that's very important. Again, for those that need early intervention is also a class 1 indication. For those that need selective intervention, they are the one probably we talked about, they have low risk, you want to do further investigation, you want to do your coronary angio, you want to do cardiac MRIs. So you can selectively work up the patient so that you will not be doing PCI for all patients. And then the class 1 indication. There's also a group of patients, which is class 2A recommendation, which has been termed as those that you have a delay approach. The delay were initially on their own, but I think recently it was removed. And it said that you can wait, especially for those group of people that have out of hospital cardiac arrest and is due to NSTEMI, you can wait, especially if they are hemodynamically stable. There is no difference in doing it urgently or waiting for the first 24 hours. There's really no difference. So if you have a lot of logistic things in your hand, you can plan for them. These are peri-interventional anticoagulation. I will not spend my time here. I think Prof is going to talk to us about cardiac revascularization. So all this stuff will be talked about. So this is bleeding risk. Anytime you want to start anticoagulation for patient, you must look at the ischemic burden, and the bleeding risk is very important. For patients that are high risk, you tend to do shorter dual antiplatelet therapy. But for patients that are low risk, you do your 12 months of dual antiplatelet therapy. Thereafter, you can continue with aspirin for lifetime. But if they have high bleeding risk for bleeding, you tend to do shorter, be 1 month, then 3 months, 6 months, depending on the patients you're dealing with. Let me leave because of time. This is a concept of you can de-escalate the use of your P2Y12 inhibitors, like I talked about earlier. You can change from ticagrelor to clopidogrel to prasugrel. So if a patient have NSTEMI and you know that the patient is going to go for PCI, give the patient prasugrel. But if the patient doesn't have any bleeding risk, you rather just give ticagrelor. In a center where you have a lot of logistics, you rather just give clopidogrel. There are some individuals that have clopidogrel polymorphism. They don't respond to clopidogrel. You want to give. So de-escalation, remove and add as a case may be. That's what we mean by de-escalation of P2Y12 receptors inhibitors. And you can see that this is class 2A inhibitor. So a lot of people does it. A lot of people, they don't do it, as the case may be. So just quickly talk about NSTEMI in special population. Those that got AF, an individual with NSTEMI presenting with AF or had AF as a background problem, not presenting with NSTEMI. In terms of their anticoagulation, you have to look at the bleeding risk. You also have to look at the ischemic risk. So if the ischemic risk is high, you continue your triple therapy, which includes your NOAC and then dual antiplatelet therapy. So that's the triple therapy. So you can continue for up to 1 month where you continue your NOAC and single antiplatelet therapy for 1 month, and then thereafter continue with your NOAC. But if the bleeding risk is very high, you want to do a shorter duration of your antiplatelet therapy and NOAC. So the idea here is that you need to compare both the bleeding risk and ischemic risk. So if the ischemic risk is more, you tend to take a longer time with the triple therapy. If the ischemic risk is less and you're having more of bleeding risk, if you do a shorter time in terms of because the patient is going to bleed. So some of these slides, you get them and then you can look at it later. So this is still talking about what I've just said, chronic anticoagulation, bleeding management. Of note is that dabigatran have an antidote, which is either ruzumab. And then once you have vitamin K associated bleeding events, especially once you're bleeding actively, you need to give your protein complex concentrate, which contain a lot of protein. Okay, then patient with cardiogenic shock, talked about that before, is an indication for immediate intervention. And most time, you may need to secure the hemodynamic status of those patients. So those are the kind of patient you want to put your intra-aortic balloon. Okay. So, and then, like I said, emergency, and that's class 1 indication. So, diabetic patient, ensure that the sugar is not more than 180. Diabetes causes diffuse issues. So, I know I'm getting out of time. Patient with CKD. CKD is a risk factor for bleeding. So, for that, you need to be careful of your anticoagulation, the renal status, contrast induced nephropathy, and all that. You have to consider that that's a class 1 indication. For the elderly individual, you don't have to treat them differently from every other person, but just realize that is an elderly person that prone to a lot of side effects of your antiplatelet, anticoagulant. So those are class 1 indication. So lifestyle, well, all patients that have done cardiac surgery or PCI should undergo, or had NSTEMI should undergo cardiac rehabilitation. And those are class 1 indication. Take-home message. So far, I've said that clinical history, ECG, troponin are recommended for diagnosis of NSTEMI. Troponin should be done 0 hours or 0.2 hours, 0.3 hours, depending on the logistics in your environment. Non-invasive investigation are recommended for low to intermediate probability for NSTEMI. Echo are recommended for NSTEMI in order to assess ischemic changes, complications, and rule out other causes of chest pain. NSTEMI patients should be re-stratified to early so that you will know whether you want to intervene immediately, early, or selectively. All patients should receive dual antiplatelet therapies through anticoagulant before PCI. Patients should receive anti-angina medications, include beta blocker, calcium channel blocker, nitrate, Nicora-D, Ranolazine, as the case may be. NSTEMI patients should receive high-intensity statins. Once the EF is less than 40, you should commence on MRAs and ACIs or AROBs. Timing of PCI should be determined by patient clinical status or local logistics. Patient clinical status and station of the lesion at invasive coronary angiogram should be decide the type of revascularization vis-a-vis PCI or cardiac surgery. Talked about some of these things before. Let me not repeat myself. Thank you and welcome any question, and forum is open for interaction. Thank you.
Thank you, thank you, thank you. Thank you very much, Dr. Kweki, for keeping to time. Thank you for the excellent presentation. Some colleagues have already typed in some questions, but I'll call on Prof to give us additional information on the topic, then we'll take the questions.
Well, okay. Thank you, Dr. Kweki, Chief Kweki, for this fantastic presentation. It's very fantastic. I hope I'm audible.
Yes, you are.
Yeah, thank you, thank you. So thank you, Dr. Ugo, also for coordinating. He has said everything that we need to know concerning NSTEMI. Okay. Just wanted to just buttress some of his main comments when he started. First, he talked about level of evidence. So we all know level of evidence, and he mentioned something about meta-analysis. Sorry that I'm just starting from there. Meta-analysis. Don't forget, meta-analysis is said to be, well, one of the highest level of evidence. Okay. And as he also rightly said, meta-analysis is collection of all clinical trials regarding that particular study. So we are talking about NSTEMI now. So meta-analysis of whatever they've done on NSTEMI, either in terms of treatment for NSTEMI or in terms of investigating NSTEMI or clinical approach to NSTEMI. So meaning you focused clinical trial on any segment of this condition. Now, why am I mentioning this? There's also what is called systematic review. So systematic review or systematic analysis is similar to meta-analysis, okay? They won't ask us in the exam, but it's important you know that they are similar. But the main slight difference is that meta-analysis can involve different methodologies for assessing the same condition, while systematic analysis would try to streamline the methodology to be sure that they have well-aligned methodology. For example, let's take NSTEMI, for example. We want to see what is the outcome of patient that had immediate vascularization compared to those, or what is the outcome of immediate vascularization in high-risk patients. Now, methodology could be that some clinical trial just said within 2 hours. Methodology could also be some clinical trial says within 1 hour. Are we getting it? So meta-analysis will take either you take within 2 hours, within 1 hour, within 3 hours, as long as it's early revascularization or sorry, immediate revascularization. You didn't wait for 24 hours. But in systematic analysis, it will take, if it's within 1 hour, every study is going to analyze will be within 1 hour. If you say within 2 hours, every study is going to analyze within 2 hours. So that's just a subtle difference between meta-analysis and systematic analysis or systematic review. So that anytime we are reading and looking what's the difference, they look very the same, but their methodology will align for systematic review compared to meta-analysis. Okay. I appreciate the clinical criteria or the algorithm he gave us for how to prepare these patients for interventions in terms of those that need early intervention, those that based on the risk stratification. Is very important for exam, knowing the risk stratification of these patients for what to do for them. It also mentioned about medical therapy for them, that means the drug therapy, when those that are class 1 evidence, those that are class 2B, and those that never do, class 3. Okay. What I would have wished Dr. Kweki would also explain to the group would be, for example, in the medical therapy, where they talked about some things you should that falls under class 3, meaning that don't do them. For example, using the GP, that's glycoprotein inhibitors, 2A and 2A and 2B and 3A and 2B and 3. Now, remember they said it there that it should not be used in patients whose coronary anatomy is not defined. So it will be good you ask quickly, what does it mean when you say coronary anatomy is not defined? And what does it mean that if you say, okay, even if you know the coronary anatomy, when should it not be used? Even, okay, we know coronary, okay, say coronary anatomy not defined. Now you now know coronary anatomy. When should it not be used? You get what I mean?
Yeah.
Because you can see the English clearly stated there, coronary anatomy not defined.
Yeah.
Don't use, right?
Yeah.
Now, let's say we have defined, you've done angio, you've defined the coronary anatomy. So what are they actually talking? What are we looking out
So
for?
what's that statement? Sorry, I didn't have all the time to explain all details. Because coronary is not defined, so you're not sure whether you're going to do PCI or you're going to do surgery. Because if you do the angio and you see triple vessel disease, left main disease, do this Sinta score, and you think that this patient needs bypass surgery, and you've already given things like prasugrel or ticagrelor, you have to stop, or clopidogrel, you have to stop there about 5 days, 7 days before the procedure. So that's a contraindication for surgery. So you wouldn't want to give because you're not sure of the coronary status of this patient to decide the intervention you want to follow, whether you want to do PCI or you want to do bypass surgery. So that's one of the reasons you don't give. In fact, in prasugrel, they said that you're only giving if you know that the patient is going to undergo PCI. That is, you know the coronary and this patient is going to do an angio. That's when you will give. For the glycoprotein 2B3A inhibitors, they are really recommended for patients that have inflow problem. You've done your angio, put in your pacemaker, and then there's no flow, either because you've opened up a lot of the thrombus, they've gone to distal aspect to go and block it. So your TIMI flow is low and there's no flow. So you're having kind of inflow problem. So you want to give them the glycoprotein 2B2A inhibitors. So that's what you want to give them so that you can help enhance flow across the coronary arteries. Okay. Example is like things like tirofiban. So you give things like that. I think that's one of the things that we commonly use over here for patients that have this problem. So I hope I helped with that. To look forward to this stuff. Is it clear?
So thank you very much, Chief. So it's important we've emphasized to our colleagues that tirofiban should be used when there is a lot of clots or procoagulant effect in the coronary vessels. Okay, so if there's high thrombus load, that is when you should consider. And in those kind of patients, they will present